Hello, everyone. Welcome. It's Wednesday, June 6th, and today is Ask the Doctor session. And this is Dr. Velma Scanterbury, medical consultant for Dialysis Patient Citizens Educational Center. We have another wonderful day here in Delaware. Wherever you are, I hope you're enjoying the weather. We are officially now past Memorial weekend and into June, even though we haven't quite started, had the start of summer, which is the middle of June, but we are having great weather. We're able to get outside more often. So thank you all for joining. Again, I'm Dr. Scanterbury, and I'm so excited to see all of you on here already, early and ready to go. So thank you for joining. And for those of you, I see some regulars, Yolanda and others who have been here before, but if any of you are new and this is your first time, I want to say welcome to this live kidney chat with me, Dr. Velma Scanterbury, retired transplant surgeon who's now practicing primary care and chronic care disease management here in Wilmington at the Delaware Health Equity Coalition. Thank you, Alethea from Detroit, Michigan. Welcome, Greek for Truth. Thank you so much for joining. And we're here to talk about any and everything and topics related to kidney transplant, getting on the transplant list, navigating while you're on the transplant list, and also if you're on dialysis, the question, you've been on dialysis and you've been there for years, have you been referred to a transplant evaluation? Have you been turned down for transplant information? And also in terms of those of you who may be advocates, who may have others who may be on dialysis. One of the things that we're seeing now that especially for those as we get up in age or people who may have disabilities, we need to advocate for each other. As you go to the doctor, or as you go to the clinic, as you see your specialist, oftentimes they don't have enough time to sit down and talk to you. So you want to be able to learn more about your disease process. You want to learn about what your options are. Thank you from Utah, transplant recipient and advocate, wonderful. And ask more questions. I say if your doctor is intimidated by you asking questions or they get annoyed, then maybe you need to have a conversation with that physician or provider, because they're there to be able to have a two-way conversation. Oftentimes, as some of my patients would say, when you develop kidney disease and you're in the process of looking at renal replacement therapy, you are given so much information. You're told what to do. You can't do this, you can't do this, stay away from this, stay away from that. And so oftentimes sometimes you want to just say, well, what exactly can I have a voice in? So you want to be able to say, how can I do better for myself? If there's all these things out there that are bad for me, what can I do better for myself? So certainly there were a couple questions in the chat. I'm going to stop being so chitty-chatty and answer some of these questions. I'll go back to your question, Nancy, but Syrian, one question is, what is your experience with ileal conduits? And so for those of you who may not be familiar, there are those patients who may not have a usable bladder. Let's say they had bladder cancer, they've had issues with not being able to urinate from the bladder, or it's just missing or not useful. Then as you put the kidney in, you have to figure out where will you divert the urine in order for the urine to actually get out of the kidney to the outside. And so for those patients, you'll do an ileal conduit. And so what you'll do is that you'll detach a segment of your small bowel, the ileum particularly, because you don't want to use the colon. There's just too much bacteria in there. And so it's still alive and connected to its blood supply. And you close one end and you bring that other end out as a stoma. to the outside. And so when you put the kidney in, you place it in a position inside the abdomen that you can then connect the ureter or the drainage tube from that kidney to the bottom of this ileal conduit, which is be like a sac, and it has a stoma that comes to the surface. And so you then are able to do that for those who don't have a bladder or usable bladder. Certainly for kids or others, adults who may have suffered trauma, this may be the only way of having the urine exit the body. And so therefore you wear a bag, or you may have a small opening. For some people, you may tunnel it through a small area of your appendix, where you bring the appendix to the surface and have a small opening that you can catheterize a couple times a day to empty the urine, or you may use bag. So, and sometimes it's necessary. The risk is just generally of keeping it free of. Usually, there are those who may have to place a catheter, but the urologists who are the experts at doing that, if I have to do it or there's a need to do it, I will, as a general surgeon, I will call the urologist, and who has a specialty and really knows how to make these the best interest of the patient, so that they are not draining urine all the time. In some cases they can, or they can have use a stump of the appendix where you just pass the catheter down. And so yes, for some people that may be necessary. Thank you for that question. I hope that I answered your question helpfully. So I established with my doctor that I was actually a member of the care team, and I told my doctor as much. It helped me planning a lot. It helped my planning a lot. And that's very important. You want to be part of your care team. You want to be able to have a decision in what you are supposed to be doing. And it's always ask questions such as, so what are the alternatives? Is there another option for me? If this doesn't work, what is plan 2? Those sort of things. I have long time vascular issues. I'm 43 years old, since age with kidney failure. I have a small venous ulcer, and I'm nervous. So, one of the things certainly is with patients with long-term long-term kidney disease, depending on the cause of your kidney disease, and whether it's diabetes, hypertension, chronic kidney disease, access, certainly all of these things can contribute to vascular problems. And also for many patients, you're constantly using your extremities or your blood vessels in your arms. For many patients, they run out of access because they've had fistulas, they've had grafts in their neck, they have catheters that will then cause narrowing in the subclavian vein in the neck, which make it very difficult to then have a working fistula or graft below, because now you have a narrowing as the blood exits from having a catheter up here, and that can be a problem. So for many people, once they have a dialysis catheter in the neck, they like to keep it because it's convenient. But remember, the longer it stays there, it will cause trauma to that vein, leading to narrowing and causing difficulty with outflow when you're then have to have something downhill from that. So anything in the arm can then be jeopardized in terms of not draining well, because it comes to a standstill or very narrow lumen in your neck. So vascular issues are a constant problem for patients on dialysis. At some time, patients will run out of the access, or they may need to change from one site to another. So be careful. That's your lifeline. If you are on hemodialysis, even if you're on PD, you want to make sure that your catheters are free of infection, because one of the things that lead to patients having to switch from peritoneal dialysis to hemodialysis is they then lose the ability to have successful rinsing of their abdomen because of either chronic peritonitis, thickening of the peritoneum, and dialysis no longer works because now the membrane is so thick that you cannot have transudation of fluid from one side to another. So yeah, many people would have lots of catheters, but you also want to not stay with catheters but to move on to having a fistula. We have many fistula first programs, but unfortunately, there's so many people who do not have adequate veins to be able to accommodate success of a fistula. So thank you for your questions. Glad for the conversation. I see many of you are seeing each other, and I'm glad that this is a medium for you to come back together with each other. So thank you for joining. I know in the beginning, Nancy had a question. Let's see what it was. I think she asked about phosphorus and why is phosphorus not good for us? And fortunately, the calcium phosphorus metabolism goes out of whack when you have end stage kidney disease, and so you have to keep phosphorus cannot exit the body easily, and so you have to bind it. And so it's important that when you take in foods that have phosphorus in them, you need to take your binders. And when you don't take your binders, or you don't take enough binders in proportion to the amount of phosphorus in your foods, then you have absorption of that phosphorus, which then becomes the building blocks for what we call atherosclerosis. And so you have thickening of the arteries, we have laying down of plaque disease. And so for many patients, when you're monitored on your dialysis treatment, it's really about how compliant you are with your taking your binders, and how successful you are with keeping your numbers below 5 or below 6, whatever for maybe the range for your dialysis unit. Because one of the things we see with patients who are listed for many years for transplant, while they're waiting, when they started at year 1, they had pretty decent blood vessels, but because of issues with phosphorus compliance, now at year 5 or 6, they have very hard plaque in their blood vessels. And for many of these patients, they can be denied transplant because now your atherosclerosis or your plaque disease have advanced significantly, that now it's like hard as rock or hard as calcium. And the surgeons are saying, I can't cut through this. So phosphorus is very important, that you take your binders, that you keep your numbers within normal. And for those of you who are joining, I am Dr. Velma Scantberry. I am here discussing your questions, live discussion with Ask the Doctor about concerns for anything you may have related to end-stage kidney disease, chronic kidney disease, kidney transplantation, getting on the list, anything related to that arena that I can answer. And we've been having a good conversation about advocacy. We've been just answering a question that was asked earlier around the effects, the downsides of phosphorus. And I think we have a session coming up in 2 weeks where we will talk more about the consequences of high phosphorus. Derek and Jack, I was diagnosed with MPGN 25 years ago. The transplant team told me that the same issue caused my transplant kidney to fail after 11 months. Do I try again, or is this not meant for me? Unfortunately, MPGN2 is one of those glomerulopathies that do reoccur and cause significant protein excretion. Certainly, it's I've seen many patients who reoccur, but I've also seen some where we have been able to come up with a better combination of immunosuppressive drugs that may work. But certainly, when you reoccur the first time, there's always a higher incidence that you will reoccur the second time. And so the repeat is, there's certainly that issue in terms of trying to decide, is this something I should be doing? Are there better immunosuppressions out there? Was my disease quiescence at the time of the transplant? We have a lot of discussions with our transplant team as to whether patients who are at risk for recurrent disease should go on dialysis, have the proteinuria dissipate, shut down the kidneys, wait a while, and see if we can decrease the rate of recurrence. Some say it doesn't matter. Some say, you're looking at a 60-40 chance. There's some FSGS maybe 40-60 in favor of recurrence, but there's also those 60% that may not reoccur. So it's a discussion to have. What was your immunosuppression? What was your protein excretion before the time of dialysis? Did you still have activity that was present on the biopsy, or were you not on dialysis? So there's so many things that would go into the discussion. At what point do you get retransplanted? So it's not an absolute no, but it does require a very robust discussion with your transplant team to look at both sides of the equation. What are the pros and cons of going through this process again, knowing that there's an X percentage that you may reoccur depending on your biopsy and many other things that happened before then. So thank you for the question. Certainly the recurrent disease is is certainly an issue that we deal with, but unless you say there's 100% reoccurrence, there's still an option for some patients to get transplanted. And I've seen some people reoccurred, and I've seen some did not reoccur. So it's looking at both sides. So thank you. Thank you guys all. I'm Dr. Scanberry again. I'm a medical consultant here on Kidney Chat, and ask the doctor questions regarding dialysis, how to get on the transplant list. I'm wondering if anyone other than advocates have success educating patients about using social media to advocate for a donor. One of the things that I used to participate in was another platform that allowed folks to come on, and I can't think of the name now, but it certainly allowed for, I actually had a couple sessions where there were many advocates, whether it was living donors. There was a living donor platform, and living donors came on, and they talked about their journey. And during one of the sessions, one person was on who talked about his need for a transplant. There were a family member who wanted to donate, and they actually linked upon social media on that platform and was successful. So it's one of those things that we definitely need to spread the word about, not just social media, but just advocacy in general. I tell folks, look at your different circles of what you belong to, whether it's your church. Even if you don't find a donor, think about the fact that you'll be educating people about kidney disease. Your whole disease process, your whole process of going through chronic kidney disease, end-stage renal disease, being in need of a transplant, can educate so many people who may not have or understand the course of which end-stage renal disease occurs. And so as long as you have an audience, then you have the ability to educate even just one person, whether it's your book club, whether it's your bingo club. So many people are not aware of the fact that diabetes, hypertension are the two leading causes of kidney disease. We think about heart disease, all the other issues, and then there's so many other diseases that cause kidney disease and end-stage renal disease. You as each and every one of us here, as well as those who know you and know your story, have an opportunity to use social media to educate others, to help them use social media to advocate for themselves or others. So each one teach one. So I welcome all of you to begin to think about how you can really help others, either around you or either within your own arena. So thank you for that. I have a friend at dialysis that's blind. She's 50, living in assisted living. She was told last week she was denied a transplant because of her assisted living. And so the question is her independence. Can she get back and forth? Who is going to help her? Are there people, when you're in assisted living, the question is always, who is going to be committed to bringing you to the hospital or to clinic on a regular basis? Or are you having to depend on someone getting you there? Who's a family member who is going to be there? If you're sick in the middle of the night, is it that you have to call the ambulance? If you're going to take your pills, or who's monitoring taking your pills? What's the pharmacy? How are you going to get your medications delivered? How are you going to, so all those things from the social service standpoint has to be discussed. And generally, I'm not there. I can't tell you why they denied her, but it's usually a combination of what is life expectancy in terms of, will the transplant improve her quality of life and allow her to do things and live longer than without the transplant? And so that becomes an issue. And so that discussion needs to be had so that they can make that decision. So it's not just a one decision, but it's everybody at the table. So I think thank you for that question, but there's so much that goes into that equation, and it's more than I can actually dive into at this point. So thank you. I think when you tell your personal journey with kidney disease, it humanizes the need for donors to so much more effectively. That is true. As a transplant surgeon, I can stand up there and talk a lot about kidney disease, but whenever I go out to do education, I make sure I bring one or two patients with me. Somebody on dialysis, somebody's had transplant, somebody's waiting, a living donor, because it's their experience that drives home the story. It's the fact that they were willing to do this, and that people can then ask them questions about their process. Was it easy? And some donors are very honest. They say, this was hard. I had complications. I had a hernia. I stayed in the hospital longer, but I would do it again. Even talk to patients who had a kidney transplant and it didn't work. They had a rejection. It failed. They had to remove it. But you know what? They were off dialysis for, say, 2 months, 3 months. As a surgeon, I'm very disappointed. I'm not thinking, oh gosh, how could I have done this to this person? But for that person, they said, I didn't have to go to dialysis for 6 months. Even though I was in and out of the hospital, they said, I still want to do this again. I'm willing to do this again. I'll take the chance. And those are things that often those stories will propel and help others. And so it's always gratifying to be able to share your story, positive or negative. You don't want too much negativity, but you want to be able to share your story. So thank you so much for that. Thank you for the Kidney Corner podcast. Definitely check out social media and look at ways that you can help others. Welcome to Instagram Live with DPC. I'm Dr. Scanterbury. I am your medical consultant here to answer your questions. So we've had a live discussion, and thank you all for joining. How do patients maintain better fluid control in hot weather? I never got to that, but that was one of my topics in terms of thinking about how do you not overload. And so you really want to think about ways you can keep cool. Use a water fan, fan with them, blow cool water on your face so you can stay cool. The frozen grapes is always a good way to keep cool. You buy your grapes, you keep them in the freezer. The coolness of the frozen grapes is a good way to be able to get your fruits in without overloading, but you still get that quench your thirst in a way. And so freezing your fruits or freezing your liquid so that you use it as a slushy, and you know how much you're consuming. So you set out your amount, and you want to not go over that unless you have a way of burning up some extra fluid. If you're still urinating, it's a lot easier from that perspective. But during the summer, maybe another session we can talk with ways of how you can effectively maintain your, stay cool without definitely getting in onto the bad side by having congestive fluid overload and needing to go to the hospital. So you want to stay inside when it's hot so you don't get heat exhaustion, but you definitely want to be creative. And on the DPC education website, there's certainly lots of, they do have nutritional corner, things you can eat, different recipes for different foods, things you can make to enjoy the summer without and take part in all the good things that are there, but in limitations. So thank you for that question. If anyone is aware of any ideas that they may have, I appreciate you also sharing ways that you deal with the heat. Richard is saying, thank you. In the South, it gets really hot here. Yeah, I worked in Mobile, Alabama for 6 years, and it was very, very exhausting. And some of the challenges is they're really thinking about, okay, here's my fluid that I need for the day. Perhaps I can freeze some of this and have it and eat it slowly over time. So if you eat in ice chips or you freeze your liquid, whether it's lemonade or whatever it is, in small portions, you can then take out and be able to cool yourself down. Certainly staying cool. I see some friends of mine wear this fan around their head, or you have a portable fan with water that keeps you going. So thank you so much. I'm Dr. Scanterbury. I am the medical consultant, and we are here having a discussion on Instagram Live. And as usual, for those who are not DPC members, as Yolanda says, get involved. Go to that website. Join up. You will see so much information on there to help you on your path. You will see that you're not on this journey alone either. There's so many who may be sharing your same concerns, sharing your ability to your struggles. It's important that you know that others are in the same boat with you, and we want to help you. So there's advocacy also on there. Certainly I agree with you. It's hard to control your phosphorus when you're cooking at home. How can you make be more manageable in low income households? So it's really like that, looking at reading labels and trying to figure out what are the worst things I can eat that have high in phosphorus. You want to definitely stay away from sodas, any colas or stuff. You want to be able to say, there are things that I can eliminate that will keep my phosphorus down. And so, yes, you want to have that list of things like I'm avoiding this because it's not worth it. And I can drink this instead. So you want to be able to think out, what are my alternatives from that perspective? So thank you. At DPC, we're all in this together. And yes, we really want to hear your story. You want to read other people's stories, because when you go to the website, you have the occasion to do that. And there's so many testimonials that you can gain insight from and realize, wow, there are other people who are sharing my story, and therefore, and whether you're having some mental issues, whether you're feeling that, I'm not quite there, I might need a therapist, it's okay. It's okay. And it's, you're not alone. You're not alone, because you have a disease process that puts you more at risk to feel depressed, to feel stressed, all those kind of things. So thank you guys so much. Transplant patients facing stomach pains and loose motions, definitely talk to your doctor, talk to your transplant coordinator, so that they can tell you what you need to do. Also, the pharmacist. There's always a pharmacist in clinic, or should be, to help you with those medications and make sure that your stomach pains aren't due to the steroids you're taking. If you're not taking steroids, it may be due to something else. And loose stools can be anything from your magnesium supplements to your cell set. So those can be side effects of so many things you're taking. So I appreciate all of you. Somebody said, I love cola, but they use root beer as an alternative. But you want to make sure that when your things that you are taking are low in phosphorus. So have a great day, everyone. This has been a fabulous chat here on DPC Educational Center. We've had a great conversation, and I will see you again in 2 weeks. Take care. God bless.